Okay, now we're on to next video, vessels 2. Okay, now, what time is it? 10. We were on this, we ended up the last video on this one, the filtration absorption, the forces that cause a fluid to enter and leave capillaries. And I'll show you now the figure on page 799. It looks like it's really confusing, but I'll just tell you what you have to remember about it. Okay, so on the left, the arterial side of the capillary, on the right, the venous side of the capillary. And here's blood flowing through from the mid-arterial through the into the capillary. And it's got a lot of numbers, and I'm not going to ever give you, numbers, so you got to do math problems here to figure out net filtration pressure. Not going to do it. But net filtration pressure is the osmotic pressure versus the hydrostatic pressure. The hydrostatic pressure is a force that's pushing blood out of capillaries. Osmotic pressure is a force pushing blood into capillaries. Right? Net filtration pressure is osmotic pressure minus the hydrostatic pressure. Okay, so on the arterial side, hydrostatic pressure is up here, osmotic pressure is here. And hydrostatic pressure is up here. So net filtration pressure is positive, which means that there's more fluid being pushed out of capillaries than being pushed in. And as we move across the capillary, hydrostatic pressure drops. Remember, it has to drop, otherwise fluid would be flowing in that direction. So hydrostatic pressure drops. So notice osmotic pressure is not changing, and it drops once the hydrostatic pressure drops below the osmotic pressure. Now the net filtration pressure is negative. And when that happens, the net filtration pressure is negative, and water is forced from the interstitial fluid into the blood. And remember, that is because there is protein dissolved in blood, and there's no protein in the interstitial fluid. So there's a water concentration gradient across the capillary. And then the fluid flows back into the granule and goes back to the heart. So here's the thing: how there's more over the course of all capillaries in the body. There's more, well, not all, most capillaries in the body. There's more fluid forced out of capillaries than comes back in. So, as a matter of fact, only about 85% of the fluid that's forced out of capillaries on the arterial side comes back into capillaries on the venous side. So it's 15% left in the interstitial fluid. And what happens to that 15%? That will find its way to a lymphatic capillary, and it will return to the cardiovascular system eventually in the subclavian veins via the lymphatic system. So interstitial fluid eventually becomes, when it enters a lymphatic tissue, becomes lymph. So that's on the next page, page 800, role of the lymphatic system. We're going to get to that chapter, lymphatic system and immune system, in the next chapter. That becomes lymph. Okay, so part of the role of the lymphatic system is to return fluid back to the heart, or back to the blood. Okay, local regulatory control. We look at vasoactive chemicals, dilators and constrictors. As I mentioned before, what really opens up capillaries are sometimes chemicals that cause dilation of the arterioles that link blood to capillaries and the opening up of these precapillary sphincters. There's a list of dilators and constrictors on page 803. See that substances and systems that affect blood pressure and flow on top of page 803. Decreased oxygen levels, decreased nutrient levels, increased carbon dioxide, histamine, bradykinin will all cause dilation, cause more blood to be brought to these capillaries. Decreased oxygen levels, decreased nutrients, decreased CO2, prostaglandin, thromboxane's a thing, or vasoconstrictors, and will decrease the amount of blood that comes to capillaries. Then there's reactive hyperemia. This is the book gives a good example of when you coming from a cold environment, you go into a warm environment, your blood gets flushed, because if you restrict, remember in the cold, what about you restricting blood going to your skin, and it just has a minimal amount of oxygen, and when all of a sudden you get you change conditions, you open up the capillaries suddenly, and you get this reactive hyperemia that opens up capillaries. That's on page 802. With tissues deprived of needed oxygen nutrients, medical waste accumulate, and when you have an increase in blood flow to the tissue, you have a really leaky capillaries, and you get the penalized blood. Okay. Responses to damage. These open up. These cause vasodilators like bradykinin and histamine to open up. So there's in damage, you want to bring more blood to tissue because it brings more white blood cells, brings more oxygen, and helps to repair damage. And then there's local blood flow. This is on page 800. What kind of things affect local blood flow? One is degree of vascularization in angiogenesis. How vascular is this tissue? The more blood vessels there, the more blood can be brought, the more metabolically active it could be. And so, so this is the degree of vascularization. Some tissues are very, very vascular. Bone, for example, is, if you remember from last semester, bone is very vascular. Skeletal muscle, this is one of the things that happens when you exercise, if you do cardiovascular exercise. You increase the vascularization of your skeletal muscles. This is called angiogenesis, making new blood vessels. So when you work out the cardiovascular exercise, when you're not making bigger muscles, you're increasing the oxygen delivery system, the cardiovascular system, to bring more blood to skeletal muscles. On the contrary, if you become a couch potato, you have regression. You actually will reduce the amount of blood vessels there are in skeletal muscles. Some tissues are very, very have almost no blood vessels or no blood vessels, like tendons, ligaments, tendons, the cornea of your eye doesn't have any vascularization. There are no blood vessels in those tissues. So it all depends upon the tissue. We talked about how vascular eye is. But the more vascularization, the more blood flow. The myogenic response is on page 801. This helps to maintain blood flow to tissues despite possible changes in blood pressure. When you stretch skeletal muscle, when you stretch smooth muscle, it reflexively contracts. So if we increase it, so if your blood pressure increases for some reason, more blood is brought to the tissue, the vessels are stretched, the smooth muscle reflexively constricts and reduces the amount of flow. So pretty much stays the same flow, changing blood pressure. The blood pressure drops, these muscle reflexively relaxes and opens up vasodilatation and allows more blood to come through. So when you have changes in blood pressure from a moment to moment, blood flow to tissues pretty much remains the same. Okay, and that local suture regulation is the vasoconstrictors, vasoactive chemicals we just talked about before. And continues on page 802, talks about nitric oxide, very powerful vasodilator, and prostaglandins and thromboxanes are powerful vasoconstrictors. Okay. Total blood flow equals cardiac output. Total blood flow all over your body equals cardiac output. Heart rate times stroke volume. And that's from the heart chapter. Okay. Now, going from blood flow, and we'll get to blood flow later on. We'll get blood flow confused with blood pressure. Blood flows because of blood pressure. And so that's what the first part of the slide is. There's a pressure gradient. There has to be a pressure gradient from one vessel, one part of the vessel to the next. If you want blood to flow in this direction, you gotta have higher pressure over here than over here. There has to be a pressure gradient. All right. All right, and then how do you measure it? The measurements are systolic pressure, diastolic pressure, and pulse pressure. Systolic pressure is the pressure in your blood vessels when your heart's in systole. Diastolic is the blood pressure in your vessels in between the beats, right? Pulse pressure is diastolic. Systolic minus diastolic is pulse pressure. But here's the thing, it's hard, you want to have like an idea of your average blood pressure. Because it's pulsatile in the large arteries, it's pulsatile. It's high here in the pulses and low here in between pulses. So so to get an idea of what's good, you want a mean arterial pressure. So why don't you just add the systolic and diastolic and divide by 2? And that would be mean. But that would be misrepresent the actual mean arterial pressure because most of the time your heart is in diastole. And so those are longer than this systolic. So to get a better pressure, a better idea of what your mean arterial pressure is what they do is they take diastolic and 1/3 of the pulse pressure. And that's what like their mean arterial. And too low blood pressure is called hypotension. Too high blood pressure is called hypertension. And here's the thing, those can mean different things with different people. I mean, if you take the blood pressure of most people, you get an average. Remember, it's blood pressure is always given in 2 numbers, like 120/80. And so that's systolic 120, diastolic 80. So that's a mean for all kinds of large numbers of people, but to you it might not. You might have a naturally higher numbers than other people, and other people may have naturally lower numbers. And so with 120/80, what would mean arterial pressure? Let's give an example of that. So diastolic 80 plus 1/3 of pulse pressure. So 80 minus 120 minus 80 is 40. So that's the pulse pressure. 1/3 of pulse pressure would be then about 12, about or 13. So then So then you add 13 to the 80, you get about 93. 92, 93 is like the mean arterial pressure if you're systolic and diastolic, or 120 over 80. Right. So the blood pressure changes relative to distance from the heart. It's pulsatile. You feel a pulse until capillaries. So I guess it's even pulsatile a little bit in the arterioles until capillaries will become laminar. It's laminar flow. And then on the venous side of the cardiovascular system, it's laminar flow. There is no pulse in veins. Okay, here's how everybody's had their blood pressure taken, and probably you take blood pressure all the time. So there is systolic pressure and diastolic pressure. So how do you figure this out? When you take a blood pressure, when you squeeze up that blood pressure cuff, what you're doing is stopping all flow into your lower arm. All right, and then you ease off that pressure. And here's the thing: so you don't hear any sound when you squeeze up and block all blood flow into your lower arm. You don't hear any sound. You release the pressure, and you start hearing a sound. Why? That's because of turbulent flow. If you open up the vessels just a little bit, flood churns out and hits the side of the vessel, and it's turbulent flow, so it causes noise. So that's systolic, because now you've opened the vessel just enough so the greatest pressure is pushing through. That's systolic. Then you ease off the pressure and keep on hearing a sound. Ease off, and then finally you get to a point you ease off enough where the sound disappears. Now you're going back to laminar flow. So that is wide open now, and you have laminar flow, and the laminar flow doesn't cause any sound. So that's the diastolic pressure. Right? And here, as you can see in the bottom of this slide, on the left side is the arterial side. You can see how we have a pulsatile flow all the way down until the purple with capillaries becomes laminar, and the venous end and then the rest of the venous side is not pulsatile. And notice the pressure drops from aorta to arteries to arteria to capillaries, venules, veins, vena cava, back to the heart. It continuously drops. And it's even lower in the atria, it's even lower in the ventricles. And it has to be remembered because otherwise the blood wouldn't flow. You got to have so from one side of the heart to the other side of the heart, you have to constantly decreasing blood pressure. All right, so what you want is blood pressure that's high enough to perfuse tissues for gas exchange and nutrients and things of waste products, but low enough not to damage delicate tissues. I mean, these capillaries are pretty delicate. They're only a thin layer of squamous epithelial cells. It's a basement membrane. So high blood pressure can break those and cause hemorrhage. Okay. Venous blood pressure and venous return. So we know that the arterial side, higher blood pressure than the venous side. So the venous side is a low pressure system. So for the blood in the veins in your head and neck and shoulders, that's no problem getting back to the heart because gravity assists. But what about the blood from your lower extremities below the heart? This you have to get this blood back to your heart, and it's a low pressure system. It's a really fight against gravity, right? And it's a smaller gradient, and so there's a couple of things that help bring blood back to the heart. A couple other pumps, so to speak. So we'll talk about these two pumps, and also Valves in veins help prevent backflow, which is push the blood up. These are one-way valves, which is pushed up the blood onto one pass one valve, it can't flow back. Some people in their legs have leaky valves, and some of the blood can flow back on the other side of the valve, and this is a varicose vein. We have little bolts in varicose veins. Okay, let's look at the skeletal muscle and respiratory pumps that help venous return from the lower parts of the body. Okay, on the left is a skeletal muscle pump. So walking around, moving your muscles, squeezes veins and helps push blood past these valves. And then when the muscle relaxes, the blood can't flow back because the valve is one way. So moving helps to keep blood flowing and moving back up. That's why I mentioned in the blood chapter about the danger of sitting down for a long time. If you got a long plane rides, the blood starts to pool down in your lower extremities because you're not squeezing those muscles, and that blood tends to slow down, and slow blood tends to coagulate inappropriately. Okay. On the right-hand side of the slide is the respiratory pump. Now we haven't gotten to respiration yet, but there is reduced pressure in your thoracic cavity, and this helps you suck air in when you breathe, but it also helps to suck blood from the lower part of your body. So when you breathe in, the one thing that happens is your diaphragm pushes on your abdomen, your abdominal muscle squeezed, it helps push blood back. When you breathe out, the pressure inside your lungs decreases below the pressure in your abdomen, and this helps to suck blood back up into the heart. So we have both the skeletal muscle pump and respiratory pump, as well as the heart to help bring blood back to the heart, from the lower part of the body. The blood pressure is systemic circulation driving force to move blood pressure gradients. Directly related to total blood flow. The more blood flow, the higher the blood pressure. The lower the blood flow, the lower. How to change pressure gradient, change cardiac output, and also directly related. So you want to change the pressure gradient, you change cardiac output. You want to increase your blood pressure, you increase heart rate. You want to decrease your blood pressure, you decrease heart rate. So any kind of positive chronotropic factors will increase blood pressure, negative ones will decrease blood pressure because they increase or decrease heart rate. Or stroke volume. Increase stroke volume, increase blood pressure. Decrease stroke volume, decrease. So negative inotropic agents decrease blood pressure, positive inotropic agents increase blood pressure. And that's a directly related. All right. Okay. So what kind of things affect blood pressure? We naturally get a little more hypertensive with age. Our blood pressure tends to go up, and our body tolerates that for some reason. And that's because our arteries become less elastic. Everything becomes less elastic with age. And, so when arteries when blood is pushed through the arteries, they bulge out. And they become a larger space. Remember, larger space means lower pressure. Smaller space, higher pressure. So they bulge out to a certain large space, and the pressure could be 120 millimeters of mercury. but that stretching is allowed by those elastic lamina, but they become less elastic with age. So they don't. So as you grow older, they don't stretch out as much as they used to. The space is smaller, therefore the pressure is higher, and you're going to have a little bit of higher blood pressure with age. Okay. Variables that determine blood pressure. It was mentioned cardiac output, heart rate, and stroke volume, and this is due mostly to neural input, the sympathetic and parasympathetic nervous system. Blood volume. This refers to how much blood is in your body. This is like a water balloon. Like you think of your home, a blood supply as a water balloon. The more water you put into the balloon, the higher the pressure inside. So anything that changes your blood volume, and it raises your blood volume, raises your blood pressure. And then it decreases your blood volume, decreases your blood pressure. And we're going to look at things that affect that. And this is mostly a hormonal regulation for blood volume, and those two are directly related. Higher cardiac output, higher blood pressure, higher blood volume, higher blood pressure. Resistance to flow is inversely related. This is how hard is it to push blood through these vessels, right? And that has to do with the size of the blood vessels. The greater the size of the blood vessel, the easier it is to push through, the more blood flow. The smaller the blood pressure, the harder it is to push through, the higher the blood pressure in that vessel. So constriction of blood vessels all over your body will increase blood pressure. A dilation of blood vessels all over your body will decrease blood pressure. And that's called resistance to flow. The greater the resistance to flow, the higher the blood pressure, the less resistance to flow, the lower the blood pressure. So what affects peripheral resistance? So that's it. Peripheral resistance is the resistance to flow through tissues and all over your body. One is blood viscosity, how viscous your blood is. And this is pretty much due to how many formed elements there are. And the biggest part of formed elements is red blood cells. So it really depends upon hematocrit. What's your hematocrit? The higher your hematocrit, the more oxygen you can carry through your blood, but the harder it is to push through because it's thicker. You know, it's harder to push a molasses through a pipe than water. Vessel length. How long is the vessel? The longer the vessel, the greater the pressure gradient has to be to push blood that distance. And the corollary of that, and the same thing, is how many blood vessels are there? You got a lot of blood vessels, you need a higher blood pressure to push through lots more blood vessels, or to make more blood vessels. But those two things affect peripheral resistance, but your body does not control blood pressure by changing either one of those. What it does is the vessel radius. How big is the blood vessel? The bigger it is, the easier it is for blood to flow in, or the lower blood pressure. The more constricted it is, the harder it is to push through, the higher the blood pressure. So this is something that your body uses to help determine blood pressure. What is the diameter of blood vessels all over your body? And that's controlled by the sympathetic nervous system. Because blood vessels are only innervated by the sympathetic branch of the autonomic nervous system. And there's a motor center in the medulla oblongata that is a sympathetic center, and it will determine the size of blood vessels all over your body by stimulating them or not stimulating. If they stimulate them, the vessels constrict, become smaller. If they don't stimulate them, the blood pressure inside will push it apart and cause the vessel to dilate. All right, so those things are which is really important. Okay, blood pressure and resistance. The flow now through blood vessels is it's not blood pressure; it's blood flow through blood vessels is controlled by what's called delta P on the numerator. Delta P is the pressure gradient across the vessel. The higher the pressure gradient, the more flow. And that's direct relation. Flow is decreased by resistance. It's an inverse relation. The more the resistance, the lower the flow. And delta P mostly controlled by cardiac output. Right? And R is mostly controlled by diameter, particularly diameter of peripheral vessels, particularly the arterioles. That's the biggest change in blood pressure across the cardiovascular system. It's in the arterioles. So the size of the arterioles all over the body has a great effect on the blood pressure. If they're constricted all over your body, your blood pressure goes up. If they're dilated, your blood pressure goes down. And this is controlled by the vasomotor center in your medulla oblongata. Okay, that's like a half hour, so I gotta call and we'll pick up on that on the next video. So long, see you in a bit.